It's nice to see you extending your global reach of this program, so thank you for inviting us. One of the side effects of the virus issue is that there's no admin in the hospital now, and I actually wasn't informed about this talk until about half an hour ago. But fortunately, Rachel Vanderland has prepared a beautiful slide deck, it looks like, and Rachel is coming on staff here at the hospital in January and is one of the world's leading experts in molecular pathogenesis of pulmonary vein stenosis, which is one of the unsolved problems in congenital heart disease, as you know. So we'll go through her slides together. Cecilia, what is the time? Yeah, okay. So pulmonary vein connections obviously are either normal or abnormally connected. Abnormal connections are then, in terms of classification, either totally anomalous or partial anomalous. The main issue with anomalous pulmonary venous drainage is pulmonary vein obstruction or repair, either occurring in the primary presentation or following repair of total veins. And then there's a third category, and we'll go through all of these with examples. Perhaps the most challenging is primary pulmonary vein stenosis, and that refers definitionally to the situation in which the pulmonary veins connect normally anatomically to the left atrium as they should. However, they have intrinsic stenosis. So those are the subtypes of pulmonary vein obstruction in terms of classification. So in terms of, looks like an embryology slide. So the embryology of pulmonary venous anomalies is very confusing to me, and I'm sure I can't explain it in a very articulate way, except to say that it's really a failure of incorporation of the pulmonary venous structures into the posterior aspect of the left atrium during development. And so this is what normally happens, but if it's abnormally incorporated, there'll either be absence of connection or a narrowed connection between the pulmonary vein confluence and the left atrium proper. And that occurs embryologically, sort of in an orchestrated fashion, along with septation of the atrium and involution of the systemic venous connections. And there are several of those, and they tend to be confusing, but it's probably not so germane to our discussion today of pulmonary vein stenosis. So again, this is the embryology of partial versus the total morphological substrates for total anomalous pulmonary venous connection. So here she cited the lack of myocardial sleeve, abnormal smooth muscle cell development, and myocardial differentiation in the left atrium, typically in association with a small left atrium. It's plausible, I suppose, that some of the abnormal smooth muscle cells would undergo a fibrogenic proliferative response, which may account for or contribute to the pathogenesis of pulmonary vein obstruction, but that's only speculation and not proven. So this is an example of the types of partial anomalous pulmonary venous connection that we observed. These are schematics. And the main feature is that there is anomalous connection of the right upper and middle pulmonary veins in about 85% of patients. We see that in association with the atrial defect shown here involving the superior portion of the atrial septum. So the entrance of the veins is very close to the atrial septal defect in terms of flow patterns. Now, an unusual but interesting form of partial veins is referred to as scimitar syndrome. And the reason for that description is that the scimitar vein resembles a scimitar. I don't know if you recall what a scimitar looks like, but on the AP chest X-ray, this shape here is reminiscent of a scimitar sword, in which the vein connects to the junction of the IVC in the right atrium. And this is really a constellation of lesions, the scimitar syndrome. So it's obviously the primary feature is the anomalous pulmonary vein connecting to the IVC, but it's also seen in conjunction with typically extreme hypoplasia of the right lung, and even sequestration of parts of the lung and diaphragm eventration. So it's really a constellation of lesions with a spectrum of severity depending on really the development of the right lung. And it requires a special consideration for treatment, and I think we have a slide about that. So this shows the repair of the usual form of partial anomalous pulmonary venous connection. Typically, it's done in children 2 to 4 years of age because it doesn't present as an emergent situation with pulmonary vein obstruction, as we'll see subsequently in the case of total anomalous pulmonary venous connection. So you can see the atrial defect that I referred to involving the superior portion of the atrial septum, and it's closed with a pericardial patch. Our preferred operation here is really a double patch repair. So we use one patch to conduct the anomalous right upper pulmonary veins posteriorly through the defect into the posterior left atrium, the way they're supposed to be connected, using an autologous pericardial patch. And remember that I mentioned that the veins typically connect in close proximity to the atrial defect, so it makes it a relatively straightforward patch that is rarely becomes obstructed. So it's not, so obstruction of the patch is not really a clinical issue. The second patch is really a vertical patch that straddles the caval atrial junction. And the reason for that patch is that the first internal patch can sometimes compromise the SVC or confluence with the right atrium, so it can become narrowed right here where my pointer is. And so, as I said, the purpose of the second patch is to decompress that area and improve the caliber of the caval atrial junction. Sometimes we can inadvertently go too close to the SA node, which is located right there, and generate atrial arrhythmias in about 5% of patients. Although the first patch, the interior patch, is not really susceptible to obstruction, the caval atrial patch, often you'll see a small gradient of 2 or 3 millimeters of mercury at the cephalad, most superior portion of the patch where it extends onto the SVC. This is particularly common in patients in which the anomalous veins connect high up close to the innominate vein. So the right uppermost pulmonary vein may, in about 10 or 20% of patients, connect very high up close to the innominate. So that means that the internal patch goes a long way into the SVC, making it more potentially compromised in terms of its caliber. But it's rare that that patch needs to be revised or intervened on in any way. And we do leave the mixture, trying to make sure technically that we leave the azygous vein intact, because that's a natural decompression compression for that pathway in the event that there is mild narrowing of the SVC. So we'll now turn our attention to total anomalous pulmonary venous connection, which obviously is more serious, multi-factor associations, as is the case with most forms of congenital heart disease. You do see it in association with syndromes. In this case, Holt-Oram syndrome is the most common. And total veins can cause pulmonary vein obstruction, which, as I mentioned at the outset, is the real issue that we're dealing with clinically, and is the topic of this presentation. And in the case of right isomerism and total veins, it's a very complex, challenging lesion, and I think it's fair to say that we haven't solved all of the issues, and survival remains, long-term survival remains a problem in the setting of single ventricle right isomerism and total veins. And one of the reasons is that pulmonary vein obstruction is quite common, 40%. So these are the classical types of TAPVC. So they're divided into supracardiac, cardiac, and infracardiac, and mixed. So those are the mixed shown here. Those are the main subtypes. The most simplest end of the spectrum is the supracardiac, and this shows that the pulmonary vein confluence, instead of connecting to the left atrium the way it should, connects through a systemic venous connection, in this case the left vertical vein to the innominate vein. And so this pathway rarely becomes obstructed, and these kids can be operated on at 3 to 6 months of age, and 3 months of age, probably preferable, because, as I said, they rarely get obstructed. Cardiac type, typically the anomalous pulmonary vein confluence connects to the coronary sinus, and so this can be repaired simply by unroofing the coronary sinus and closing the atrial defect. Rarely these types of lesions will have a secondary stenosis right at this level, where the confluence joins the coronary sinus, and so they may develop a delayed obstruction, but that's unusual. And the most challenging form is the infracardiac type, occurring in 25% of patients. And you can see that the anomalous systemic venous connection of the pulmonary vein confluence is through a descending vertical vein, in this case connecting either to the hepatic or to the portal venous system. And this is very susceptible to and extrinsic and intrinsic compression, and therefore often is associated with obstruction. And we'll come to the clinical presentation in a subsequent slide. And this shows the mixed type occurring in 5%. So in this case, for example, there's anomalous left pulmonary vein stenosis on the left side, and on the right side, the looks like a single pulmonary vein confluence connects to the right atrium instead of the left atrium. And so these are repaired with independent surgical attention to each of the lesions, or they can be repaired through a common type of repair, a sutureless repair, which I'll describe in some detail. This format here is very challenging, and the reason is that when you disconnect the anomalous left pulmonary vein, whether it's draining part or all of the left lung, but especially in the case when it drains the entire left lung, you have to rotate it 90 degrees, as it were, to connect that vein to the left atrium. And so it forms a right angle post-repair, where the anomalous vein is draped over the left hilum, the left bronchus, and the left pulmonary artery. So it's often kinked right at that level and can be very challenging to address. So I think that's still also one of the unsolved problems in pulmonary vein surgery, is this particular morphological subtype. So the pathophysiology, it really depends on whether there's obstruction or not. As you can see, it's kind of a binary presentation. The challenging one, of course, is the neonate with obstructed intracardiac or mixed veins, because they present as newborns with a whiteout chest X-ray, pulmonary edema, hypoxia, and cardiogenic shock. And that's one of the few lesions in congenital heart surgery that requires repair within the first few hours of life. Most other lesions can be temporized, as you know, with prostaglandins, etc. But this is one exception to that. In some cases, I'm not sure exactly what the percentage is. If there's any delay going to the OR, we would place them on ECMO just to support the cardiopulmonary function prior to repair. In some patients, and I think we have some examples of this, there is an emerging role for stenting the anomalous systemic venous connection in order to decompress the obstructed pulmonary vein confluence in complex single ventricle patients. So this shows the effect of pulmonary vein obstruction on long-term survival, stratified by the morphological subtype. And you can see that the infracardiac type has the lowest, statistically lowest survival, long-term survival based on a large, I think this is a multi-institutional cohort of patients. You can see that preoperatively 40% had infracardiac veins had obstruction, and so preoperative pulmonary vein obstruction was a risk factor for survival, as was younger age at operation, and early postoperative pulmonary vein stenosis also presaged a less good long-term survival in this particular study. So we talked about stenting as an interim bridge method to decompress the pulmonary venous circuit. And this is actually a nice angiographic slide of decompressing the vein. You can see on the image on the right, there's a stent, so an improved caliber of the connection. So this shows the classical surgical repair of total anomalous pulmonary venous connection. This is to the left vertical vein, so this is a supracardiac type of veins. And you can see that basically anastomosis is made between an incision in the left atrium, shown here, and the pulmonary vein confluence, shown here. And so you can see that that's a direct connection. The problem with pulmonary vein surgeries is that the veins are very thin-walled and susceptible to external compression or fibrosis or alteration in their configuration just from changing the configuration of the pulmonary vein left atrium junction. So the heart can lie on top of the pulmonary vein confluence and sometimes distort the flow, because remember that these pulmonary veins may be 2 to 3 millimeters in caliber, so it doesn't take much to compress them and produce non-laminar flow. Non-laminar flow being one of the purported risk factors for postoperative pulmonary vein stenosis. So this is just shows the classical repair. This shows repair of the intracardiac or coronary sinus type, which is perhaps the most straightforward repair. You can see that the coronary sinus is opened up here, or unroofed. You can see in this image here on the right-hand side with my pointer. And that then creates an unobstructed opening between the pulmonary vein confluence and the left atrium, which is on the other side of that unroofed coronary sinus. And then we close the resulting atrial septal defect with the pericardial patch. And so there's no operating on the pulmonary vein confluence itself. And so this has a very good prognosis. So what is the incidence of pulmonary vein stenosis after repair of total veins? As shown here. And you can see that early postoperative pulmonary vein obstruction, shown in this line, sorry, this is the patient cohort that had early postoperative pulmonary vein obstruction, and they had a much higher risk of dying after the surgery. We can see that pulmonary vein stenosis occurs about 10 or 15% of patients following surgery, and that's almost irrespective of the type of repair that's used. And if pulmonary vein obstruction becomes severe, I guess what Rachel is saying here is that it becomes like a functional single lung if it's on one side, and can present, or bilateral, and can present with recurrent infections, hemoptysis, and may require pneumonectomy to deal with the infection, or even lung transplantation. So it can cascade or spiral into a very lethal scenario, and I'll show you some examples of that morphologically. So this shows that when a patient develops post-repair pulmonary vein stenosis, there is the opportunity to intervene either surgically or with a catheter. And you can see that delays the risk of death, or this shows the rate of death or re-intervention by surgery or catheter. And so the take-home message there is that recurrence of pulmonary vein obstruction so in other words, a patient comes with post-repair pulmonary vein obstruction, has an intervention, either surgery or by catheter, and that again predicts a less good survival outcome, as shown on these actuarial curves. So even if you treat the recurrent pulmonary vein obstruction, you still have a significantly lethal situation. This just shows that when pulmonary vein obstruction occurs, it typically manifests early. You can see within the first 2 years, the number of events predominate over the long term in terms of the early hazard function of pulmonary vein stenosis post-repair. So in terms of the anatomical substrates, and this is important because it tends to guide the management and the prognosis, the three subtypes cited here: anastomotic stenosis, so this is discrete, sort of circumscribed right at the stenosis due to fibrous tissue, and that can be addressed by removing the fibrous tissue or cutting across it. Fibrosis of the confluence is a little bit more extensive because it involves the entire confluence and is more of a pernicious fibrogenic response, which I think in my experience or whatever would be that I really view this as an accelerated fibrogenic response, just like you would get fibrosis of the left ventricle in heart failure with preserved ejection fraction, for example, or renal fibrosis. So it's really a fibrogenic response, and that the pulmonary veins are not very well equipped, given that they're so diaphanous, not very well equipped to resist that fibrosis. And then finally, you get the most severe form called retrograde or upstream, and that term was coined by my colleague Chris Calderon, who referred to the progression into the lungs as the upstream secondary lesion that becomes difficult to control in post-repair pulmonary vein stenosis, or in primary pulmonary vein stenosis, an example of which I think we have later on. So these are the risk factors that that should give you an index of suspicion, if you will, that you may have post-repair pulmonary vein obstruction. Small patients less than 2 kilograms are risk factor for everything in our business, right? So this is the rationale for modification of the repair. Just to be clear, I didn't call it the Coles repair. This is Rachel's calling that. I prefer to refer to it descriptively because it's more indicative of what the procedure is and creates less confusion, and that is a atrial pericardial anastomosis. So it's really a connection or anastomosis between the left atrium and the pericardium. So, as I mentioned before, distortion can cause non-laminar flow, which can precipitate endothelial cell injury, and then all of the molecular players that can become activated in endothelial injury. Not terribly dissimilar, I guess, to what you see in atherosclerosis, where you have an endothelial injury but then through crosstalk with the media and so forth, produces a more transmural lesion. So this is an example of the modification of the repair, which was designed to minimize the amount of flow disturbance, increase the caliber of the pathway between the pulmonary veins and the left atrium. So you can see we have a proposed incision in the left atrium, just inside where the left pulmonary vein confluence is in this case. And this shows this actually shows the position of the phrenic nerve. Okay, so this is, you can see that we make incisions into the secondary branches of the pulmonary veins, sometimes even the tertiary branches, right up to the level of this is the, meant to represent the pericardial reflection shown here with my marker. So this shows the incision in the pulmonary veins. This is the left atrium opened up with incisions into the left superior and left inferior pulmonary vein in this case. And then what we do is suture the pericardium, the left atrial edge. So this is the edge of the left atrium where it has been opened up. And we suture that to this suture line to the actual pericardium, which in this suture line, the dotted lines show that the suture line circumscribes, goes outside, but does not connect directly to the incision in the pulmonary vein confluence. So thereby avoiding direct physical continuity and potential distortion on the pulmonary vein confluence. So that's the principle of that type of repair. And it just shows that I think this is meant to represent that we try to improve the flow, the caliber of the flow pathway. So the bigger the pathway, then the more latitude you have if there's some incongruity in the or distortion of the edges of the pathway. If you have a larger pathway, obviously, you have more room for error, as it were. So when we looked at the incidence of restenosis following repair, and this is not primary repair, I think it's repair of postoperative pulmonary vein stenosis, and we looked at the sutureless method that I just described and compared to the conventional repair. And this was a multi-institutional study, I believe. You can see that there was a clear advantage to using the modified repair in terms of the risk of subsequent restenosis. So the rationale for it, as I said, is a larger caliber flow pathway, and can be applied sort of universally for any type of pulmonary vein stenosis, whether it's primary or following earlier repair in which there's recurrent pulmonary vein stenosis. So it can be, the repair can be standardized, doesn't need to be individualized, and can be applied equally to, let's say, mixed pulmonary vein stenosis. And this is an example of it here, the more detailed description anatomically. And you can see that in this case, we've made the incision into the pulmonary veins, the left upper pulmonary vein, the left lower pulmonary vein, and then the opening in the left atrium. because I'm out of sequence here. So the left atrium is opened, the pulmonary veins are opened, and then you're going to connect the left atrial incision, the edges of the left atrial incision, shown here, to the dotted line, which, as I said, is to the pericardium, not to the pulmonary veins. Hence, the designation atrial pericardial anastomosis is the most accurate description. And you can see that we don't touch or suture. We don't suture directly to the pulmonary vein confluence, thereby hoping to minimize distortion of that structure. And then you can see that as the repair progresses and the suture line is made, that we're creating a fairly large caliber connection between the left atrium and the pulmonary vein confluence using the pericardium. I will say that this dotted line represents the phrenic nerve, and so you can see that that's quite close. Obviously, it's on the exterior surface of the pericardium, and so we don't necessarily see it directly, but we're aware of its proximity. And that's certainly a risk of left diaphragm paresis after the surgery, although it doesn't seem to be a common clinical problem. So what are the issues with the repair? We have seen entrainment of air, presumably from a disruption of in the lung bronchial network, so you can entrain air into the left atrium. I think we've seen one case of that. You can have pleural disruption, so the suture line is to a fairly thin pericardium mediastinal pleura, and that can become disrupted or cause bleeding there. And so we probably have 3 to 5% incidence of bleeding there. Typically, though, we can recognize it in the OR before we close, so you can see bleeding where there's a breach in the connection between the atrium and the pericardium, and so we can close it with a simple suture working from outside the pericardium. So there's no circulatory arrest here. We can lower the flow a little bit to improve visualization. So as I said, that operation can be applied irrespective of the individual morphology and whether or not it's mixed or infracardiac or whatever, so that it becomes a more universal application of that procedure. And we can see that there's a reduction in, this is another study, it was not from sick kids, showing that the sutureless repair was associated with a lower rate of restenosis in patients with pre-op pulmonary vein stenosis. So that was actually a large number of patients, 768. So this just shows the algorithm. Just final subtype before we finish up is perhaps the most challenging, but also, I guess, fortunately, the least common form, and that is primary pulmonary vein stenosis. So remember I said that that is when the veins connect normally to the left atrium, but they are intrinsically stenotic right at the point where it connects. And that's depicted schematically in this diagram. You can see that there's fibroproliferative neointimal hyperplasia, which is compromising the lumen here and extending out into the lung parenchyma. So these are the upstream, so-called upstream pulmonary vein branches. And you can see on this pathological slide that it's really, I like to view it as atrial endocardial fibroelastosis involving the left atrium, but extending into the pulmonary veins. And you can see that there's, in this case, there's just pinpoint openings into the right upper pulmonary veins. The left pulmonary veins look to be okay here, fairly good caliber, but on the right side, you can see that they're significantly obstructed by this fibrogenic reaction. And that is also observed histologically. You can see that normally this should be wide open, but it's obstructed by this blue containing matrix consisting of largely fibroblasts and collagen, fibrosis, basically. And in this case, it's quite a cellular lesion. I think that's represented by this expanded micrograph view here, showing that there's actually cellular proliferation that's in some way contributing to this obstruction. So the question is, how do you treat this? Because it's clearly different from other forms in which there's discrete level of stenosis, which can be, surgically enlarged or cut across. So once you get progressive pulmonary vein stenosis, you can see that the 1-year survival is only 57%, and that's irrespective of whether it's primary or non-primary forms of pulmonary vein stenosis. So these are patients you're selecting out of the worst patients, the ones that have shown a predisposition to be recurrent. So by definition, they've had some other procedure and still present with pulmonary vein obstruction. And so one of the things that Rachel's been instrumental in developing at our hospital is a multi-institutional team-based approach in which the surveillance is really stepped up on these patients if they have any clues or indication that they have pulmonary vein obstruction, and trying to develop experience with different medical and experimental therapies to see if the disease can be interdicted in any way. And at the same time, we're doing experimental work in the lab to look at the molecular events that contribute to this disease. So the team approach involves sort of more serial, stepped up echo, CT, MRI, and cath, in which you can do earlier, which would allow earlier detection, early intervention, and we're doing that now. So if we see any recurrent stenosis in the pulmonary veins, they will be addressed with transcatheter approach with balloon dilatation in an attempt to sort of forestall the otherwise relentless progression of the disease that we see historically. So as Rachel has indicated here, we try to match the surveillance and the interventions to the velocity of the disease. The velocity of the disease is really sort of patient-specific and not really predictable in advance. And this just shows the some of the algorithms that we use. So you can see that following this consortium, I'm not sure what CPS refers to, but it's the consortium of pulmonary vein interventionalists, if you will, that they've really shortened the time from surgery to 3D imaging from 131 days to 52 days. So this means that if we can detect it earlier, at least gives us the opportunity to try to intervene and perhaps try new interventions in a multi-institutional format, which would allow us to learn faster, basically. This just shows the sutureless repair. So even with the sutureless repair, it's not a silver bullet. And regardless of whether it's primary or non-primary indication, we still see that there's an important risk of death in the long term following this repair when it's done for postoperative or recurrent pulmonary vein obstruction. So just because you have this operation, it doesn't mean that you're not going to develop evidence of recurrence. This just shows the emergence of catheter-based interventions. There are newer stents that, as you know, elaborate rapamycin and things like that, that should serve to mitigate fibrogenic response. We know that the success of the stents is related to their size. So bigger caliber stents have a better outcome. Same thing that you see basically in pulmonary arterial field, pulmonary arterial interventions for stenosis, is that the success in large part depends on the caliber of the initial caliber of the vessels. This shows we have some experience with lung transplantation, even in young patients less than a year of age. And I'm not sure exactly what the multi-institutional number is now, but we certainly have had success in this hospital with it. And the results with lung transplant are about the same as they are for any indication for lung transplant. So pulmonary vein stenosis doesn't mean that you're going to have a worse result after a lung transplant than you would for other lung transplant indications, for example. It's shown on this slide. This just shows some of the work that was done. I was involved with some of it, but primarily it was Rachel, in the lab, in which we had a porcine model of pulmonary vein stenosis, and you can see that we implicated TGF-beta and angiotensin II signaling in the abnormal fibrogenesis that you see in the banded animals. And that was the rationale for starting losartan, angiotensin II inhibitor, to try and delay the progression of that. Other centers have tried more aggressive chemotherapy type regimens. Gleevec is a tyrosine kinase inhibitor, for example. And Avastin is a VEGF inhibitor that's been used in the oncology field with the premise, I guess, that these fibrous reactions are similar to oncogenic response. And but I think the data is I think it's fair to say is mixed on that. Because it's not cancer, basically, and it's probably, in my speculation, is that it's more of a accelerated fibrogenic response, and there is no good treatment for accelerated fibrosis for any organ system. So there's a lot of pipeline drugs in fibrosis, but none have proven to be effective really in any disease indication. And so I think pulmonary vein stenosis is probably no exception to that. So I'm not going to go on much longer to say that, this is a work in progress, is understanding the mechanisms of pulmonary vein stenosis. I mean, one of the things that we're looking at now is the cytokine response. I think the whole COVID thing has refocused a lot of the molecular research on the effect of cytokines, which, after all, are the final common mediators of many diseases, including the lung disease that you see in COVID patients. And so we're looking at some of the tissue in pulmonary vein obstruction and measuring multiplexed cytokines. And we've done that in the heart, obviously, heart also in hypoplastic left heart syndrome. And we've identified some specific cytokines that seem to be associated with a better prognosis. And those are anti-inflammatory, anti-fibrotic cytokines. And so my far-fetched speculation, I say that because we don't have any specific data yet, but we've seen this in the heart, is that certain cytokines will protect against the fibrogenic response and could be potential therapeutic candidates that could be applied to this disease as well. So we'll stop there. Thank you very much.
Thank you. Does anyone have any questions for Dr. Coles? So I have one.
Okay.
So when patients have a cardiac arrest, what are the instructions for compressions?
Okay. Well, that's...
to repeat the question, actually, because I'm not sure if they can hear.
Yeah. Oh, okay. So Cecile's asking if a patient has a sutureless type repair that we described and develops a cardiac arrest postoperatively, What is the treatment algorithm, given that the suture line is, as I pointed out, is quite tenuous. The left atrial pericardial suture line is quite tenuous, and it could be susceptible to disruption if someone's pressing hard on the chest. And so, it's a difficult problem. I don't think there's any perfect answer, but what we sort of worked our way through is that if it's, within the first 24 hours post-operatively, first of all, I don't think it's very common, but when it has occurred, and if it's early on, the best thing I think is to open the chest. The chest may be open already, and to give open cardiac massage and the usual cardiopulmonary resuscitation protocols. If it's later on, let's say the patient's on the ward or something like that, and a week postoperatively, then you would obviously transfer him to the unit expeditiously and give the usual external cardiac massage. I mean, you should be aware that it may be causing disruption of the suture line, and you may have to deal with that as a separate issue. But when the patient's arresting, you don't have any choice but to give CPR and externally at that point, because the heart and substernal structures would be too adherent after a week. So it would make it problematic and too delayed to do an open resuscitation at that point. So we just, after a few days, we would just give the standard CPR protocols. Yes. So if that was in the first 24 hours is when, what I meant to say is that when the first 24 hours we would do open massage, because the structures are accessible, and you can expeditiously get the sternum open. So, typically we would have surgical expertise available within a few minutes. If we didn't, or for some reason, then you would just give the standard resuscitation, recognizing that you may cause bleeding. And so you could look for that by echo.
Good morning. May I ask a question?
Yes.
Yes. Congratulations, Doctor. It's a challenger for our specialty. How you show that the 40% of the right isomerism had pulmonary venous stenosis? How is your approach before the Glenn procedure in such patients? A special test?
So maybe you're referring to like a single ventricle with
yes,
total veins, pulmonary atresia, complete AVSD, so the sort of full constellation, the worst combination that is typical of right isomerism with total veins. And so I don't really have a good answer. It's obviously a very high mortality rate situation. What we have tried over the last few years is to, if we can, to put a stent in the connection between the confluence, the pulmonary vein confluence, and the systemic circulation. That's not always possible if it's an infracardiac. And I mean, the procedure, I guess, would be total veins repair plus a shunt. We have done it in conjunction with the Norwood operation in a few cases, so total veins plus, hypoplastic left heart. But both of those lesions are sometimes just directed down a palliative course, once the high risk is discussed with the family. But to my knowledge, there's no magic surgical or interventional approach for those patients. You sort of have to individualize the lesions, but total veins with single ventricle is a very lethal combination, it seems.
Oh, thank you.
Okay, so I think the next session will begin at 11:15, and that will be reviewing the X-ray. So it's in preparation for the OSCE, but remember, I think because there's 108 people, the OSCEs will be done in a different format. So we'll probably, we're still thinking how we're going to do it, but it'll probably be like a polling via Zoom mechanism. Anyway, it'll be fun. So that's coming up in a couple of weeks. And so for now, till 11:15, you have a bit of a break. Thank you, everyone. I think maybe the popping was coming from this mic, actually. All right.